Hello, everyone. My name is Dr. David Goldberg, and I'm here with my co-authors, Dr. Camilo Acosta and Dr. Sunil Amin, to discuss our recently published article in Gastrointestinal Endoscopy entitled Evaluating the Impact of Frailty on Periprocedural Adverse Event and Mortality in Patients with GI Bleeding. Dr. Amin and I are faculty members at the University of Miami Miller School of Medicine in the Department of Medicine and specifically in the Division of Digestive Health and Liver Diseases. And Dr. Acosta is a second-year resident in the Department of Medicine. To start, I'll ask Dr. Amin, what was the motivation behind this study?
The primary motivation of our study was to investigate the use of frailty as a means to help risk stratify patients undergoing endoscopy for GI bleeding. We currently have a number of validated tools to predict which patients may be more prone to adverse events or poor outcomes during endoscopy, such as the ASA score, Glasgow-Blatchford score, Charlson score, and some others. There's currently no consensus for any of them as a definitive predictive model. Frailty has recently been shown across a variety of disciplines to be a robust predictor of clinical endpoints. Frail patients have more adverse events and higher mortality after certain cardiac procedures and certain surgical procedures, such as colectomy and pancreatic duodenectomy. In fact, in recent years, there's been more of an effort to incorporate frailty measurements into general clinical practice. We noticed, however, that there had not been very much investigation into the use of frailty and its association with GI bleeding or endoscopy. And so given the fact that there is currently no gold standard to predict adverse events during endoscopy, and that frailty is currently being increasingly used as a clinical decision-making tool, we wanted to investigate whether frailty status could predict adverse events among hospitalized patients undergoing endoscopy for GI bleeds.
And what is frailty exactly? How would you define it in a general sense?
Frailty is characterized by a decline in functional status across several organs and is associated with an increased risk of poor outcomes in individuals upon exposure to an apparently innocuous stressor.
And Dr. Acosta, can you describe the methodology used in this study?
Sure. To summarize our methods, we began by using merged data from 2016 to 2017 of the National Patient Sample, which was the largest publicly available all-payer inpatient database in the US. Based on methodology utilizing ICD codes that had been described in previous studies, we then selected for adult patients with upper GI or lower GI bleeding who underwent either upper endoscopy or colonoscopy within 2 days of admission. We used ICD codes once more to determine which of these patients suffered periprocedural adverse events and to assign the hospital frailty risk score to all patients that met inclusion criteria. In terms of our statistical analysis, we used univariable and multivariable logistic regression models to assess the contribution of frailty to periprocedural adverse events, controlling for a number of confounders such as age, race, sex, Charlson score, and even median household income. To make completely sure that frailty was an independent predictor of poor outcomes, and this could not just be explained by increasing age, we performed a marginal standardization analysis to assess for any possible interaction. As part of this analysis, age was stratified into 10-year increments.
And what were the main results?
We evaluated a sample representative of approximately 750,000 adult patients nationwide with GI bleeding who underwent endoscopic procedures, with 44.4% classified as frail and 55.6% as non-frail, based on the hospital frailty risk score. Despite adjusting for potential confounders, we found that frail patients suffered from periprocedural adverse events related to endoscopy significantly more frequently than non-frail patients, as evidenced by periprocedural adverse events being almost twice as common for our frail cohort. Also, frail patients had a nearly 10-fold increase in mortality during admission compared to their non-frail counterparts.
And Dr. Amin, what would you say the implications are of these findings? How are they relevant to general gastroenterologists?
I think that's a really important question. As gastroenterologists, we're often in situations where we are asked to perform endoscopy on very sick patients, and we have to decide whether the benefits of endoscopy outweigh the risks. Is endoscopy really necessary? We often make this decision based on a gut feeling, but we don't usually have any objective evidence to really justify our decision. The fact that frail patients, and in this case defined by the hospital frailty risk score, have more adverse events across the board from endoscopy, as well as have an increased risk of mortality, controlling for age and comorbidity status, really provides us with the justification we need to make a decision about proceeding with endoscopy or not. And I think this is the main implication. We can't use a one-size-fits-all approach when deciding to perform endoscopy on patients with GI bleeds.
Great. Now, Dr. Acosta, what are the future directions for this type of work?
Eventually, we envision the use of frailty assessments as a practical tool that can be used as a quick method of evaluating patients when deciding whether to pursue endoscopy or not. For example, this could be done by creating a pragmatic bedside frailty test that would serve as a proxy for the hospital frailty risk score. Through a prospective study, we can then investigate the utility of this type of quick bedside assessment in guiding decision-making and risk stratification of patients with GI bleeding who may or may not benefit from endoscopy.
Thank you both so much for your time and attention, and thank you for this exciting work.